Good morning, everyone. Hope everyone had a great holiday season. Happy New Year to everybody. Hope everyone has a happy, healthy New Year. Today's grand rounds, we have 2 to 3 speakers, depending on time. Today's topics and presentations, we have Barbara Balgerworth, who's a registered dietitian from Mather Hospital's Department of Bariatrics. She's going to be talking about the role of diet and inflammation to reduce joint pain and spine pain. A very large role for how diet plays a significant part in helping to reduce inflammation and therefore reducing pain. And then after that, we're going to move over to non-operative care of disc herniation. Our first speaker there will be Zach Riggio. He has a doctorate in physical therapy from our Department of Physical Therapy at Mather Hospital. He's going to be talking about the McKenzie method in some detail about how that is an excellent technique to reduce disc herniations. He's going to talk about different types of diagnoses. And then time permits, I'm going to go over a case of chiropractic medicine utilizing spinal decompression and flexion distraction for the outcomes of non-complicated disc herniation with radiculopathy. Before we get going, just a couple of orders of business. This is an approved CME session for Mather Hospital and doctors and physicians, nurses, practitioners, and PAs. This is one approved CME. There's a QR code that you will receive. It's not very clear, but you will get this by email today or tomorrow. Just scan this. This is only valid for 48 hours, but if you scan it, it'll take you to a registration site, and MDDO PANPs can get one CME at no charge. Physical therapists that have logged on today will have your attendance sheet. Department chair at Mather, Lisa Malcolmson, will handle getting physical therapists their CE. It's 1 CE. And chiropractors, if you want 1 CE, unfortunately, Northwell doesn't cover this. You can get a certificate just like everyone else by using the QR code, but we have to certify our CEs through New York Chiropractic College, or now Northeast College of Health Sciences. And that requires an additional fee, as in the past. If you have any questions, you can email me or call me. Lastly, Northwell Department of Education requires that we send everyone an evaluation survey shortly after this. It's literally like 5 questions. It'll take you 10 seconds digitally to do. I'm required to get as many answers as I can in order to be recertified. So I'd really greatly appreciate it if most of you could take the literally 60 seconds to do it. And then in about a month, they'll send an outcome survey along the same lines. Okay, I want to thank everyone for attending this early in the morning. I want to thank our speakers for agreeing to present and putting these great PowerPoints together. And without further ado, Zach, can you get Barbara started?
Hi, good morning. Welcome, everybody. Thanks for coming this early in the morning. So today I'm going to be talking about nutrition and diet perspectives for chronic inflammation. I don't have anything to disclose. So defining inflammation. So most people are surprised to learn 2 things about inflammation. One, it isn't diagnosed as a disease or a condition. It's more like a fire in the body, one that starts small and contained, but can easily be provoked and spread, increasing our susceptibility to chronic conditions. And not all inflammation is bad. There's 2 types, one of which actually keeps us healthy. So we've got acute inflammation and chronic inflammation. So acute inflammation, that's our immune system. It's fighting off bacteria or an infection in order to heal. So we'll see fever and swelling. Chronic inflammation, this is more of a constant attack of healthy cells. We're going to unpack in the next couple of slides, and it can lead to many disease states: cardiovascular disease, diabetes, cancer, Alzheimer's, obesity, metabolic syndrome. So when these inflammatory mediators, C-reactive proteins, cytokines, growth factors, kinase are released with inflammation, pain may also be present. So this is just a good diagram, I thought, that sort of illustrates how different external sources here, so allergic reactions, chemical irritants, infection, trauma, injury, burns, cuts and wounds, frostbite, that can lead to acute inflammation. Chronic inflammation, on the other hand, here you can see it's leading to these conditions that I mentioned on the aforementioned slide. So acute inflammation, just to get into the weeds a little bit, inflammation is a natural protective response by our immune system to some form of stress. Now, when the immune system detects an antigen, it triggers this inflammatory response, sending white blood cells to the area under attack and secreting these inflammatory compounds known as cytokines. What follows is this mounted attack of white blood cells and cytokines to get rid of the antigen, or in the case of injury, to stop additional tissue damage and assist in blood clotting. Macrophages, which is, as we know, a type of white blood cell, tend to the damage and remove debris once the situation's under control. And again, noticeable signs of this include things that I mentioned before: swelling, pain, redness, fever, pus, flare up quickly, but then they go away, and the inflammatory response subsides. With chronic inflammation, this inflammatory response is triggered and it doesn't resolve or go away. It becomes dysregulated and hyperactive to environmental and lifestyle factors. Things like toxins in our food, water supply, inflammatory foods, a lack of adequate sleep, a sedentary lifestyle, and unmanaged or ongoing stress and obesity can contribute to this chronic inflammation. It's this dysregulated, hypersensitive immune system that perceives these factors as antigens or irritants that elicit, aggravate, and escalate the existing inflammatory response. Now, this results in the production of free radicals, which can in turn lead to oxidative stress. So, oxidative stress is basically just this imbalance between the production of free radicals and the ability of the body to counteract or detoxify their harmful effects through neutralization by antioxidants. So we've got our free radicals that cause our oxidative stress. Oxidative stress causes chronic inflammation. Antioxidants neutralize these free radicals, and they come from food. So just a reminder about what free radicals are and where they come from. Free radicals are just unpaired electrons in our body. They're unstable atoms that can damage cells. They cause illness, aging, can lead to chronic inflammation. And the lifestyle factors can accelerate their production. Things like obesity, exposure to pesticides, air pollution, smoking, alcohol, processed foods, fried foods, all contribute to the production of these free radicals. But the beautiful thing is that the antioxidants that are present in our foods, all they do is they donate an electron to the free radical and they neutralize it. So now it's no longer harmful. Just another illustration I found was, informative to the different causes of inflammation in our body. So things like, now I want to stay on this just for a second, if you don't mind. So high intakes of calories, carbohydrates, sodium, or alcohol. Not all carbohydrates. We're talking about refined and simple carbohydrates. Now, I can do a whole nother lesson on this, but I just kind of want to touch on it for a second. And that's the contribution to these ultra-processed foods that are ubiquitous in our culture, that are very available to us, right? So they're going to contribute to not only excess calories, but it also affects our gut microbiome and it dysregulates that, right? So a consequence of that is if we're not feeding the healthy bacteria in our gut, and therefore the pathogenic bacteria proliferate, they could damage the lining of the intestinal wall, and that can increase intestinal permeability, which allows particles to enter the blood supply sooner than they're supposed to. And this can also contribute to that inflammatory response. Okay, we can move on to the next slide. Thank you. So there is a correlation between obesity and chronic inflammation. So when there's an increase in abdominal fat, these adipose cells grow and they change shape. Adipose tissue can release inflammatory mediators like cytokines and chemokines. So individuals who are obese also tend to have elevated CRP, which has been correlated to body fat percentage and insulin sensitivity. And we know this obesity can promote back pain, joint pain, decreased mobility. It also can contribute to increased food intake, decreased motivation, and increased stress, which all contribute to increased inflammation. It can be cyclical and chronic. The good news, though, is that lifestyle change can help with weight, exercise, meal planning, and overall decrease obesity. So lifestyle change is really the most effective treatment against chronic disease and inflammation. So chronic pain affects an estimated 116 million people in the United States. Inflammation is common to chronic diseases, including chronic pain, as I mentioned. Patients with chronic pain have been shown to have increased pro-inflammatory cytokine levels. So these inflammatory cytokines, growth factors, and enzymes contribute to the progression of tissue damage and secondary repair, including fibrosis, granuloma formation, etc. So adipose tissue, again, releases these pro-inflammatory cytokines and chemokines. Plant foods have anti-inflammatory properties. Diet is a very important factor in inflammation and pain, and modification of diet in patients with chronic pain should be part of a comprehensive treatment plan. So pro-inflammatory foods, as I mentioned earlier, these ultra-processed foods contain saturated fats, especially grain-fed animals, trans fats, hydrogenated oils that are often in baked goods and crackers, omega-6, so that's found in corn oil, safflower oil, soybean oil, sunflower oil, and sugar, simple carbohydrates and table sugar. Anti-inflammatory foods include things like omega-3s that can be found in canola oil, walnuts, and fish, or monounsaturated fats like olive oil, peanut oil, nuts, and avocado. Of course, our fruits, vegetables, and whole grains, herbs, spices, and teas, things like ginger and turmeric, oregano, sage, cinnamon, cloves, rosemary, and green tea are all really good sources of antioxidants. So omega-6 fatty acids versus omega-3 fatty acids. Omega-6 fatty acids and omega-3s are both involved with the synthesis of different eicosanoids. So these prostaglandins are produced in response to injury or infection. Chronic production of these eicosanoids contributes to inflammation, and high consumption of omega-6 fatty acids leads to chronic production of these pro-inflammatory eicosanoids. Omega-3s have anti-inflammatory actions. Now, I want to take a step back here for a second and just explain that before the industrialization of our food supply, the ratio of omega-6 to omega-3s was 1-to-1, so they balanced each other out. But now you've got the industrialization, we've got these ultra-processed foods. What's really abundant in these ultra-processed foods are high amounts of omega-6 fatty acids. So the ultra-processed foods are contributing to inflammation just by the way of the fact that they have so many omega-6 fatty acids, and we're not getting a lot of omega-3 fatty acids. So what can we do? Well, we can source, start eating. You always hear dietitians say, eat the rainbow. Why? Well, because these foods that have these color combinations are really abundant in these phytonutrients, these antioxidants. So our blues and our purples, they contain anthocyanins. So they are prevalent in our blueberries, our grapes, our apples, cherries, blackberries, red cabbage. Our yellow and orange, they contain our carotenoids. You'll see these in our, carrots, peaches, apricots, pumpkin, etc. Our reds and pinks, well, that's where we get lycopene. Tomatoes, red peppers, watermelons. And just a note about peppers. So bell peppers in general, in particular red bell peppers, are also really high in vitamin C, more so than even our citrus fruits. And vitamin C is also a powerful antioxidant. Our greens contain chlorophyll as well as vitamin A. Kale, spinach, broccoli, Brussels sprouts, collard greens, and our whites contain quercetin. So in terms of healthy eating patterns, the dietary approaches to stop hypertension, that's the DASH diet, often prescribed by the American Heart Association. flexitarian eating plan, more plant forward. The Mediterranean diet has been studied for over 50 years, and that has been shown to, reduce overall mortality, but lots of other, conditions that are related to inflammation. And then there's the Mediterranean DASH intervention for neurodegenerative delay, easy for me to say. That's the MIND diet. A lot of research behind that diet as well. And what that does is it just combines the best of the Mediterranean diet and the best of the DASH diet. So the DASH diet basically says to consume, let's say, 2 to 3 fruits and 4 to 6 vegetables, servings of vegetables per day. What the MIND diet does is it says take those fruits and vegetables that are highest in those antioxidants. So going back to those anthocyanins that I mentioned before that are really prevalent in things like blueberries have been shown to cross the blood-brain barrier, right? So they stop things like Alzheimer's and dementia as a preventative measure. It's not a panacea, but it's just one area in lifestyle factors. I'm almost out of time, so I didn't talk about, the contribution that physical activity plays in reducing inflammation as well. But, aiming for the general guidelines of 150 minutes of moderate physical activity or 75 minutes of vigorous activity a week has also been shown to be anti-inflammatory. So what services are available for weight management? I am very, very lucky to be part of an amazing team here at Mather in the Bariatric Center of Excellence. We not only support our bariatric surgery patients, but we have a non-surgical medical weight management program. I teach all the classes in that program. It's a 12-week program. We focus on meal planning. I do a class just on the principles of the Mediterranean diet. We also talk about behavior modification, lifestyle change, and exercise. And healthy diet, healthy spine, referral to a registered dietitian regarding meal planning and foods to help with inflammation. So I also see those patients as well. And then, of course, we have people that may be candidates for bariatric surgery. There's 6 dietitians here at Mather that support all of the patients that have had bariatric surgery. And those patients get access to us for an entire year. So if you know anybody that's had bariatric surgery, or if you're treating any of these patients, please remind them that they have access to us. There's no copay on our side. Thank you.
Thank you very much. That was an excellent presentation, and obviously very apropos to January of 2023. Any questions at all? There's a Q&A section on the very bottom. I encourage attendees to go ahead and put in any questions you may have. Let's take a minute to do that. I'll start off with one question, Barbara. I know you talked about hyperpermeability. Seems like that's not really generally talked about much in GI practices, the leaky gut syndrome. In your experience, especially in the population of patients that you see, how big a role does the leaky gut syndrome play in promoting chronic inflammation? And then besides changing people's diets and switching them to an anti-inflammatory diet, are there any supplements that you generally talk about, or any reparative kind of things you tell patients to do to kind of fix the leaky gut?
So we don't diagnose leaky gut. And in terms of my patient population, I would say that a majority of my patients do suffer from inflammation, and that can be a contributing factor. In terms of what we do about it, so we recommend high fiber diets because fiber is the prebiotic that feeds the good bacteria that's in a healthy gut microbiome. Now, if somebody has dysbiosis, they can take a probiotic. I usually, if I'm talking about supplements with my patients, I always refer them to consumer labs or make sure that there's a third-party review like USP or NSF on the supplement that they're choosing, because supplements aren't tightly regulated, and you never know what you're going to get. Some can be contaminated. So I'm very, very cautious when I talk about supplements. I usually lead with food first.
Do you use any, or does your department use any types of diagnostic tests to actually make the diagnosis for dysbiosis to see what pathogens are there? Does it matter? Or do you use any type of, I know there's a particular functional test that can be done to diagnose leaky gut. Are those, do you just treat it clinically essentially?
Yeah, we don't have any diagnostic tools. I know that there are some available, and I know that in particular with bariatric patients, specifically people that have undergone a gastric bypass, um, can be candidates for developing SIBO, um, small intestine bacterial overgrowth, and that can be diagnosed with a test, a breath test, but we don't do that here. But I
Right.
have seen patients that have presented with symptoms, but again, particularly in the bypass patients.
Right. One last question for me. I don't see any other questions. So generally, when you start a person on a new lifestyle diet, whether it's the MIND diet or the DASH diet, how long do you tell patients they can expect to see? These patients have lived their life the way they have for so long. They can probably get off track very easily. So what's the reasonable expectation as we see patients when we put people on these kinds of diets to tell them that it's going to take to see a change?
I have had patients anecdotally tell me that when they're following it 100%, and it's rare, you're right, because there's so many other factors that get in the way. So this isn't to blame the patient, it's really more of a public policy issue in our food supply. But patients that do follow the Mediterranean diet very closely, and we do give them a 4-day meal plan, and then teach them how to incorporate those different foods into their diet in different ways, tell me that after only a couple of weeks, their joints don't hurt anymore, they're gardening, they're moving, they're more flexible, they have more energy. So it doesn't take very long. And on the flip side of that, just coming out of the holidays, so I've had patients tell me that when they stopped doing it, and they were sort of indulging, that they actually experienced lethargy, like they didn't have as much energy, and they did find that some of their inflammation, joint pain returned.
Great. Thank you so much. If there are no other questions, I want to thank you very much for making that excellent presentation. And also, when you leave, I'm pretty sure you're eligible for this CME also through Northwell. Thank you very much. Have a great day. And let's move on to our next speaker. So Zach Riggio, he's got a doctorate in physical therapy. He's one of our physical therapists at Mather Hospital's outpatient department of PT, and he is a certified McKenzie therapist. And he's going to talk about the role of McKenzie in treating non-operative conditions like herniated discs. Go ahead, Zach. Thank you very much.
Thanks, Dr. Ben. Hi, guys. I'm Zach. I'm a certified McKenzie physical therapist at Mather Hospital. So I'm going to talk to you about McKenzie method, conservative non-operative care for disc herniation. So what is the McKenzie method? It's also called mechanical diagnosis and therapy. It's an internationally researched and acclaimed system of assessment and management of spinal and extremity musculoskeletal disorders. It was developed by Rob McKenzie, and it's been used for about 60 years all over the world now. So how does it differ from other forms of treatment? So a lot of times people hear McKenzie method and they think, press ups or extension exercises, but it's much more than that. It's not just a method of treatment, but also a reliable form of assessment. And one of the things we're doing is we're trying to classify these patients into a subgroup based on their symptomatic or mechanical responses. So that way we can better manage them. We're not treating each patient with the same list of exercises. It's very dependent on what subgroup they're in and which movement they best respond to. There's a heavy emphasis on patient independence, and it's actually one of my favorite parts of the method because you're teaching the patients how to manage their own, back or neck pain, but also the reoccurrence of their back or neck pain, because we know once you have pain in your back or neck, you're going to have over a 50% chance of having a recurrence. We're avoiding clinical dependency. It's another differentiating factor. It's not to say that we don't use hands-on techniques, but we're aware once those hands-on techniques are no longer beneficial to the patient, we'll kind of back off forces with that and allow them to better self-manage with some guidance. Progression of forces really just refers to, we're starting off the patient with active range of motion. They're doing the movements, and we're only progressing to like clinician techniques, mobilization, manipulations when we're sure that the chosen exercise or movement is not going to aggravate them. Again, we use a combination of exercise and clinical interventions only as necessary. Next slide. So sources of pain. So there's a lot of different areas within the spine that can be sources of spinal pain. And there's a wide distribution of nociceptors in the spine that make it a little challenging to actually determine what they are. For example, some innervated structures can be, the capsule of the zygopophyseal and SI joints, the outer part of the intervertebral disc, the interspinous and longitudinal ligaments, vertebral bodies, blood vessels, local muscle, all kinds of sources that can be innervated. But an interesting study by Kuslich in 91 found that the predominant source of back pain, not the only, but the predominant source of back pain was coming from the intervertebral disc. And the source of leg pain or sciatica was coming from a compressed or inflamed nerve root. Next slide. So this is a very big study, one that I recommend you check out. It's called the Expo study by Rosedale in 2020, a study exploring the prevalence of extremity pain as a spinal source. So in this study, they took about 369 participants presenting with isolated extremity pain who believed that their pain was not originating from the spine. They were assessed using the McKenzie method, and basically they were trying to influence their extremity pain through movement of the spine. I want you to look at the two columns here. So on the left are patients or participants whose extremity pain did not change with movement or spinal intervention. On the right are the participants whose extremity pain actually did change with movement of the spine. So as you can see, very big numbers here for hip, thigh, and leg. It was 71 to 72% of patients that actually responded to spinal intervention. With the forearm, it's 83.3% of participants. Even in the shoulder and the forearm, it's almost 50% of those participants had some positive outcome with spinal intervention with their extremity pain. So these are huge numbers that we're seeing of patients that might be coming into your office saying, I have a hip problem, or I have a forearm problem or a shoulder problem, that we're possibly missing it being a spinal source of pain if we don't rule that out. Next slide, please. So some predisposing factors. Robert McKenzie found that there were two factors across all of the general public that predisposed them to back and neck pain. He called them the silent killers. One of them being poor sitting posture, poor slouch sitting posture, which is actually placing the spine in flexion and is similar to a fully flexed spine in standing. This puts a little bit more pressure on the spine. So with that flexed position, and when the spine approximates kyphosis more, there's a higher intradiscal pressure. When the spine approximates more of a lordosis, there tends to be a lower intradiscal pressure. These slouched positions also cause overstretching of posterior spinal ligaments at end range, and some low back pain is caused, but nearly all low back pain is aggravated and perpetuated by these poor sitting postures. Number two was frequency of flexion. From the moment you wake up in the morning to when you go to bed at night, you're predominantly in a flexed position or movement, and we're rarely ever extending. These frequent and sustained flexion stresses are present during the work day and during daily activities. And it's these two predisposing factors that, when combined, eventually lead to a loss of extension of the spine. And on average, we're bending forward, we're flexing the spine anywhere from 3,000 to 5,000 times per day, which is a lot. That's not to say all flexion is bad, but Robert McKenzie found that there was this phenomenon that happened after about 15 minutes of statically loading the spinal structures, ligaments called creep, where they started to actually stretch out. So as you can see in this diagram at the bottom, that purple line is posterior longitudinal ligament, actually runs along the back of the spine and protects those discs from migrating posteriorly. So we don't want to give any extra room for those discs to push backwards. Next slide, please. So the disc model is a conceptual model that MDT operated on initially. We spoke about the ligaments stretching out, the poor sitting postures, frequency of flexion. These all kind of allow that disc to migrate posteriorly a little bit more easily and possibly press on a spinal nerve, causing those symptoms down the leg or down the arm. As you can see in the picture, as the person bends forward, it places more pressure on the anterior portion of the disc, and it kind of allows that intradiscal mass to migrate posteriorly. And as you can see, when they extend backwards, the opposite happens. So there's this idea that we can influence the disc if it's herniated, and if it's maybe pressing on the nerve, to migrate more centrally so that it relieves the symptoms and restores the patient's movement. But again, sometimes the disc herniates laterally or posterior laterally and needs movements other than extension, or you could need flexion or lateral movements included. Next slide, please. So this is just differentiating between mechanical pain and chemical pain. Mechanical pain referring to the fact that the pain is influenced by the mechanics or movement of the spine. With mechanical pain, it's more commonly to be intermittent, but can be constant. Typically, movement in one direction will improve symptoms, whereas movement in the opposite direction will worsen them. Variability is a hallmark of mechanical pain. Some days are good, some days are bad, and it's largely influenced by the loading of the spine with everyday ADLs. Directional preference and treatment we'll talk about in a few slides, but as you can see with chemical pain, usually happens after some sort of inflammatory or traumatic process, and pain is always usually constant until those inflammatory cells and markers are gone, and that can be days or weeks that persists. But the big thing here is that basically it appears that no movement allows the pain to be relieved, and it is only relieved usually by rest and through medication. Next slide. So some indications for MDT or McKenzie. Could be a nerve root problem, mechanical low back pain, or neck pain. Typically, we see a lot of patients between ages 20 and 55, possibly due to the spine having fully grown at that point, and not in the later years where it starts to kind of fuse and become more stiff. But I will say that I've seen plenty of 70 and 80-year-olds that have responded greatly to MDT and movement in the spine. And in fact, I had a 73-year-old woman just yesterday with classic sciatica symptoms, and we were able to abolish them with a couple of sets of repeated movements. So they definitely can respond very well to it as well. But also, typically you see, like in the lower back, lumbosacral region, buttocks, thigh pain, and overall good health for the patient are good indications. Next slide. Contraindications: serious spinal pathology, cauda equina, cancer, tumors, fractures. Those are all things we want to look out for. Non-mechanical pain, again, we talked about chemical pain, typically is not going to respond except for with rest and medication. Luckily, the literature puts serious spinal cord pathology at less than 2%. Next slide. Some precautions: if say they're post-op and they had a fusion, we're usually not touching them until they're stable, after 6 weeks, depending on the doctor's recommendations. If it's prior to 6 weeks, we're really only looking at movement loss. With stenosis, it can be, if it's a true bony stenosis, definitely difficult to change with movement. But I will say that patients have come in with diagnosis of stenosis and have responded very well to repeated movements. Either way, the MDT assessment is used, and it is very beneficial in placing them into one of those subgroups or categories to further manage. Pregnant patients always have to be careful with. Less than 20 years old, we're going to be a little more cautious with too. Next slide. So this is the examination form that we'll use. You can see over here it has a body chart. We're looking for exactly where the symptoms are. We're looking for mechanism of injury, past medical history, surgical history, red flags. But the main thing that is very helpful on this front page is the movement better or worse section. So we're asking them what sort of things cause your pain to become worse, what sort of things seem to reduce your pain. These kind of help clue us into a potential loading strategy that might actually help us with the next section where we're assessing repeated motions. Next slide. So the examination continued here. This is the back of the form. Some things we'll look at are posture correction. You know, what happens when we put them in the correct postural alignment? Does it reduce their symptoms? We're looking at neurological testing, strength testing. We're taking baselines of movement loss, you know, to see to help us again with the repeat motion loss assessment, which is next slide. So again, with repeated movements, usually we're starting off with about 10 reps of any one of these positions, you know, whether it's in standing or lying, and we're progressing that to more than 10 reps as appropriate, depending on, you know, if they're responding to it or not responding to it. Typically, we're looking for some sort of a symptomatic response, right? Are they getting better? Are they getting worse? Or having no effect both during and after these movements? We're looking for a change in quality or location of pain, numbness, and tingling, right? We want that to come out of the arm or out of the extremity as we're moving them. And we're also looking for the range of motion to improve. If we're moving them and their range of motion is getting worse, typically that's how we know we're moving in the wrong direction. Next slide. So here we can see the classification. So derangement being the most common one and includes that non-surgical disc herniation that we're talking about. So we'll talk a little bit more about that in the next few slides, but dysfunction of the spine, it can happen in both the extremities or the spine, but typically it happens from a mechanical deformation of structurally impaired soft tissue. This is usually the result of a trauma or surgery or inflammatory process. Postural syndrome, pain can happen in the spine as a result of mechanical deformation of soft tissue or vascular insufficiency arising from prolonged positional or postural stresses affecting those structures or the contractile muscles or their tendons. Another big category, including things like chronic pain, post-surgical SI joint pain, stenosis, whiplash after MVA. So that's another big category of patients we'll see. Next slide. Okay, so derangement. What is a derangement? Again, it's typically the biggest category that we see, and it usually responds very quickly and effectively to movements. A derangement is a clinical presentation associated with mechanical obstruction of an affected joint, right? So it's in relation to the spine, it's thought that injury, compression, or displacement of that annular tissue around the disc or the nucleus pulposus results in a sort of mechanical obstruction within the spine, and that's what causes pain and limits motion. We always see that loss of motion with derangement in the spine. Again, ages 20 to 55 are typical, which we'll see. It can come on insidiously, or it can be as a result of some of those predisposing factors we talked about. Symptoms will generally change with ADLs or with specific loading or movement positions. Location of pain can be local, referred, radicular, or it can be a combination of them. It can cause temporary deformities like a kyphotic deformity or a lateral shift. These are the patients that come into you and they're like, I can't straighten up. I'm kind of stuck in this position and my back went out. Inconsistency and change is a hallmark of derangement. They have good days, bad days, again, depending on what position or movements they're doing. And then directional preference and centralization are both parts of it, which we'll talk about in the next slide. Next slide. Directional preference. So this describes that clinical phenomenon where we're seeing a specific direction or of repeated movement and or a sustained position resulting in some type of clinically relevant improvement in either their symptoms or mechanics, but not always the centralization of symptoms, which we'll talk about. Again, it's an essential feature of derangement. Next slide. So centralization, this only occurs in derangement patients. Again, it's thought that the nucleus portion of the disc is able to move in response to these repeated movements or stacked positions. And so as the disc moves further away from that nerve or compresses it less, those symptoms radiating distally into the extremities will start to come up out of the extremity and move closer to the center of the spine. And it can actually become a little bit more painful in the center of the spine before it abolishes completely. Next slide. So I just wanted to list a few studies that show centralization and how if you exhibit it during your therapy, that you will generally have a very good prognosis and good outcome. Next slide. Again, peripheralization, basically opposite of centralization. Again, if your symptoms in response to repeat movements are traveling further down the leg or further into the arm, more likely that nerve is getting pressed on and we're moving in the wrong direction for you. So that's something that we're trying to avoid during our assessment and treatment. Next slide. So this just talks about different types of herniations and displacement of discs. So displacement refers to the intradiscal mass being displaced within the annulus, the outer rim, and is largely reducible. Now, herniation, generally a non-specific term, including any of the following below. So you could have a protrusion, right? That could be where the intradiscal mass moves backward or to the side. As long as the outer wall is still competent and intact, it's largely reducible and can go away with conservative care. If you have a protrusion where it's pushing so far and the outer wall becomes very incompetent and isn't able to kind of attenuate those forces, it can then become irreducible. With extrusion and sequestration, that's where the inside mass pushes outside of the disc and usually requires some type of surgical intervention. As you can see at the bottom here, I just wanted to point out the study in '97 by Donaldson, where it said the McKenzie assessment process is reliable at differentiating discogenic from non-discogenic pain, as well as a competent from incompetent annulus. In symptomatic discs, it was actually superior to MRI in distinguishing painful from non-painful discs. So in this study, they supported their hypothesis that pain that centralizes is discogenic in nature and arises only from discs whose annulus is still intact. And two, that their pain, if their pain peripheralized and is also discogenic, but if it only peripheralizes, the outside annulus is no longer competent and cannot be reduced. Referred pain whose location cannot be changed with repeated movement, end range movement, is not discogenic in nature. Next slide. So effects of repeated movement testing on derangement syndrome. So movement will cause that disc to protrude further into the nerves, will increase symptoms and will actually decrease range of motion. Movement causing that disc to reduce or push more centrally will decrease symptoms and improve range of motion. So the repeated movement testing is a diagnostic tool to find the patient's directional preference. Next slide. So management continued here. A reduction of derangement is something we're always trying to do, right? We're trying to reduce that herniation. We're trying to reduce pressure on the nerve and find that directional preference. We're trying to teach the patient the reason for doing these specific movement and directions. We're trying to give them control of being able to treat this on their own at home when needed. And we're trying to educate them on things like posture and progression of forces, which we'll talk about. Next slide. So maintenance of the reduction, it needs to be performed regularly. Postural correction, again, whether you're using some sort of lumbar or cervical support. We're avoiding positions that may increase symptoms. Next slide. Recovery function is usually towards the later stages of therapy, right? So once they have a good 3 or 4 days where they no longer have any symptoms, they're feeling really good, we start to put them through recovery of function, where we're starting to test them with the aggravating factors that they initially had. So for many people, that can be flexion. So we'll start to flex their spine repeatedly. And if they do not have any aggravating symptoms from it, their spine and disc, they're usually in a pretty good, stable position. And we can move on to further things like, advanced core strengthening stuff and return to, ADLs and things that they maybe were avoiding. Next slide. So prevention of recurrence is important, right? We want to try to teach these patients how to avoid these things happening to them again in the future. So again, maintaining proper posture, exercising regularly, trying to understand how to manage the symptoms if they reoccur, but also trying to understand early warning signs that you're going to have another back issue is really important. Next slide. So guidelines, typically we're doing these exercises 10 times every 2 to 3 hours. It can be more than that if needed. And especially whenever they're having pain or symptoms, we want them to try this exercise to reduce those. We're using progression of forces when necessary. So that basically, again, just means we're having them do the least aggressive technique to the more aggressive technique, depending on what it is they actually need. Next slide. Again, with progression of forces, we might start at a mid-range exercise and then progress to an end range, exercise. Next slide. And we might then, at some point, if they're not responding to it, have to add some hands-on techniques, whether that's an overpressure or a clinician mobilization or manipulation, in order to help reduce their symptoms. With dysfunction postural syndrome, which we talked a little bit about, those are only resolved by the patient. Derangement syndrome, though, may need those clinician techniques in order to aid the recovery and fully reduce the disc herniation. Next slide. Okay, so those are references, and then that's my contact info if you guys ever need to reach me.
Zach, thank you very much. That was a great presentation on non-operative care of disc herniation. The McKenzie method is a very valuable addition to our armamentarium in reducing disc herniations in a non-operative conservative manner. If anybody has any questions, let's take a moment to just go ahead and type them in on the bottom. I believe, Zach, correct me if I'm wrong, we have 2 certified McKenzie therapists at the hospital, yourself and Lisa Puglisi.
Yep, that's correct.
It's a great resource to have. In my vast clinical experience, I've always found that, and I'm a chiropractic physician, I've always found that treating and including McKenzie therapy is always an extremely valuable method to help the patient avoid surgery whenever possible.
Yeah, definitely.
Any questions at all? All right, Zach, thank you very much for that great presentation.
Yeah, of course.
We have about 15 minutes left, so I'll go ahead and talk a little bit more about disc herniation management from a conservative point of view, more from the chiropractic end of things. If you have any questions at all at the end, Zach will stay on as well as I will. I think Barbara's still on as well, and we can answer questions at the end. Okay, so I'm going to talk a little bit about how chiropractors use a specific type of tool to manage a non-complicated disc herniation that may have radiculopathy as well. Next slide. So I'm going to talk about a case, and then I'll talk about some imaging and some new developments in research regarding resorption of disc herniation and some of the things that promote how disc resorption occurs. So here's a 64-year-old male. He hurt his back while working. He developed low back pain and right sciatic leg pain. He had a positive straight leg raise at 50 degrees on the right. He had a well leg raise or cross sciatic sign on the left, positive Bragard sign. He had some mild sensory hyposthesia with a pinwheel, the L5 dermatome, some mild weakness of the L5 myotome, the tibialis anterior and EHL, along with some spasm. He definitely had an extension bias, meaning everything that Zach just talked about. When he was put into extension, it decreased some of his sciatic pain. As Zach mentioned, that's centralization. And I'll talk a little bit about how that's very applicable in what we do as chiropractors as well. He had a significant high pain level. There were 0 red flags, no evidence of CE syndrome, no evidence of infection, saddle anesthesia, or any bowel or bladder incontinence. And prior to commencing chiropractic care, the patient did have a spine surgical consult. He was offered surgery. He declined surgery pending his non-surgical management. Next slide. So Zach kind of went into the nomenclature for discs. So pretty much everyone knows the disc is composed of an inner nucleus and an outer annulus fibrosis. Disc displacement, for purposes of today's discussion, we'll talk about protrusions versus extrusions. Sometimes it can get confusing, but the really simple way to make that differentiation is look at the base of the herniation. So if you look at the bottom right slide, notice how on the extrusion, the neck of that protrusion or that displacement is very narrow compared to the outer part. So when the inner part or the neck of that disc that's pushing out is smaller than the top, that's an extrusion. And you can see that in the protrusion, it's actually the opposite. In literature and also empirically in my clinical experience, and I think most chiropractors and most non-surgical practitioners would agree, Protrusions definitely have a higher prognostic level in responding to conservative care. I'd say probably, and I think surgeons would agree with me, that 90% of the time, patients with protrusions tend to get better with some sort of non-operative intervention. However, extrusions tend to be down more towards the 50 to 60% range. And they have to be really watched carefully because sometimes that extrusion, especially with that narrow neck that you see at the annular border, can sometimes tear and can sometimes become a sequestered fragment, which generally does not have a great prognosis. Looking at the far left pictures, if you look at L4, L5, the MRI, this is a sagittal view. You can obviously see where the significant protrusion is. It's a significant herniated disc at L4, L5. It's accompanied by, and it's beyond the scope of today's conversation, some modic changes and obviously some degenerative changes at the end plate. And these are modic findings. Looking at the crosscut or the axial scan just below that in the B diagram, this is a crosscut and we're looking through the canal. And if you look at your reading left, which is the patient's right, you can see how that herniation is filling the lateral recess right where that nerve root lives. Next slide. So chiropractors generally use a table called the Cox table. And the Cox table is a table that actually distracts up and down. It goes into flexion, it can go into extension. This table is very, very, very effective at helping to reduce intradiscal pressure. And the way it does that is by exerting centrifugal force and mobilizing the facet joints. Very commonly, when disc herniations occur, the facet joints usually become locked and the disc is highly avascular. There's very little blood supply. And if those facet joints, the mechanical aspect around that disc isn't mobile, and they become stuck, so to speak, very little diffusion of nutritional circulation gets into that disc, which promotes disc degeneration. So distraction can be done in flexion, it can be done in extension, and you can base it on a directional preference examination. So in this particular patient, in this case, that patient had an extension bias. So extension caused centralization of the sciatic pain. So when we did flexion distraction, or when we used this table, we actually had the patient up into extension and we're doing repetitive motions in extension. Next slide. So herniated disc, just to show a graphic picture of what happens, Zach kind of touched on this before. The intradiscal pressure increases usually 6 to 7-fold. So as the pressure increases, it causes defects in that annular wall. As those tears occur, you get an annular tear. And this is sometimes visible on MRI with high intensity zones or what they call fissures. It now can lead to a protrusion, which can affect the nerve root. And then that can cause not just back pain, but sometimes, and more often than not, sciatic leg pain as well. So spinal decompression tables, as we create this intersegmental traction, it causes a reduction in that intradiscal pressure and it pulls in nutrients, it pulls in blood supply. And I'll talk a little bit in a couple of minutes about why that's so vastly important for resorbing disc herniations. Next slide. So I don't know if this will work, but this is a graphic video of spinal disc compression in the long axis. And it looks like it may not work, but it will work. So we'll just take a moment to watch this.
So now we're demonstrating spinal disc decompression in the horizontal plane. So we're actually separating the discs from one another. By decreasing the intradiscal pressure, we can get the disc material that's bulging out or herniated out to come back towards the middle and to decrease its pressure on the nerve. As the table goes back and forth, it's creating that negative pressure, which decreases the intradiscal pressure and relieves the sciatic pain.
You can see from the motion of that table, the table's going back and forth. In this particular patient, I had the table up into extension to kind of help with directional preference of extension so that we were decompressing that disc in long axis Y, which is the horizontal plane, as well as extension. Next slide. So here's a study that I published several years ago. If you look at the MRI pictures, you can see the befores and afters from the left side to the right side. I was fortunate enough to get our MRI facilities 30 times, about 27 times to repeat serial MRI radiographs. And what I demonstrated a long time ago was that discs actually resorb. So you can see on the left picture on the sagittal, significantly sized herniation, significantly reduced several months later. And then same thing on the axial scans. And the patient, interestingly, the patient got better within, I think it was 8 to 10 weeks clinically, but it took months to see this MRI change. And that's kind of what the literature shows as well, that the anatomical outcome is lags behind the clinical outcome. And this is a well-documented concept called disc resorption. In my study, I saw it almost 2/3 of the time, with either a decreased herniation or a completely resorbed herniation. Next slide. So here's some more research studies. I'm not going to go into each one, but I just wanted to demonstrate that this process of regression of a herniated disc and resorption of a herniated disc is actually literature and evidence-based. So a lot of people, when they come to us and they say, oh my God, I have a herniation, you know, I'm never going to get better. My life is over. I'm going to have chronic pain for the rest of my life. It's actually not true. 8 to 9 times out of 10, that patient will get better with whether they do chiropractic care or they do physical therapy. Sometimes they'll need epidural steroid injections if the pain is severe enough. But the point is that usually up to 90% of the time, these patients will respond to non-operative care. That's not to say that patients don't need surgery, because oftentimes they do, but it's usually 1 out of 10 times, assuming no red flags. Next slide. So here's the mechanism of disc resorption. How are we doing on time? I have a couple minutes left. So the mechanism of disc resorption has to do with 3 processes. First one is dehydration and shrinkage. We all remember that the disc is 80% water. So as time goes on and that disc becomes a non-vacuum state, meaning there's annular tears, it's subject to the local environment, air will actually leak into the disc, and that causes dehydration and shrinkage. So as the disc shrinks, so does the herniation. The tension pressure, Zach mentioned the posterior longitudinal ligament and the anatomical function of that ligament. That ligament can create tension pressure. We enhance that tension pressure when we do flexion distraction or spinal disc decompression, and that actually helps to resorb the disc. And then lastly, probably the most important part of this is the inflammatory cascade. So Barbara mentioned in her first presentation that acute inflammation is a good thing. Well, it is. The disc is avascular, it's immunoisolated. So when a disc material protrudes into that epidural space, the immune system actually responds to that. So what actually promotes disc resorption is lymphocytes, monocytes, macrophages, and phagocytes actually breaking down that herniated disc. And that's why on repeat imaging, we will actually see resorption. Next slide. So is it only the lumbar spine? No, it happens to the cervical spine too. This was part of my case study. I'd say probably almost half of the patients that I looked at had cervical spine disc herniations. And same thing that I talked about with the lower back, the type of table that distracts the disc. This table does that for the neck as well. So I'm holding the patient's spinous process just below the level of the disc herniation, and I move with my right hand the table in the opposite reaction, whether it be flexion biased or extension biased. I'm creating tension in the posterior longitudinal ligament and in the annular fibers to create an enhanced resorption. So motion of the disc, motion of the vertebrae utilizing this table actually enhances circulation, and more circulation brings more phagocytes and macrophages to the area to actually enhance regression and resorption. Next slide. Is it only limited to patients that don't have surgery? No, patients who have had back surgery also respond very well to this technique. And my argument is in chiropractic care and in the chiropractic population of patients, I much prefer using this table than using any high velocity rotational manipulation, which I think puts the patient at risk for exacerbation. So I will pretty much limit how I treat a patient with this modern table. And in my experience, and the literature shows in this case study of 69 post-surgical patients, that patients did extremely well following this Cox table treatment. Next slide. Can't re-emphasize enough the importance of physical therapy, exercise rehabilitation. I didn't really show you before on the MRI, but there was some significant fatty infiltration on the axial scan. Very commonly, patients lose their local multifidi muscle, which is extremely important for stability of the core and the spine. So this is an extremely important part of rehabilitation of any spinal problem, including disc herniations. And research study after research study, year after year, show that no matter what kind of therapy you're doing, whether it's chiropractic adjustments or manipulations, mobilizations, physical therapy types of treatments, McKenzie, if you don't couple exercise rehabilitation with that type of manual technique, the outcomes are never as good. Next slide. I'm not going to go over this. We spoke about this in depth. Next slide. And in conclusion, chiropractic treatment is effective in reducing many types of non-complicated cases. Prior to surgery, it's my opinion that patients should have a trial of chiropractic treatment, whether it's chiropractic treatment with this table or McKenzie treatment with a physical therapist. I think it's an excellent choice before going to surgery. It can enhance disc resorption. Complication rates for using this table are extremely low, but obviously can happen. And most commonly, the adverse side effect is an exacerbation of symptoms. Best practice care, according to the literature and evidence, is that it's the combination of the application of this type of treatment with exercise and also lifestyle modifications like Barbara talked about. If you don't address diet and the patient's obese, history will repeat itself. Removing risk factors is extremely important for avoiding recurrences in the future. Complicated cases with extrusions or sequestered fragments sometimes respond well, but must be treated with caution. They have a poor prognosis and usually will require epidural steroid injections and sometimes even surgical interventions. So any questions at all, please type them on the bottom. I think there's one. For Dr. Ben, can the Cox table bring patients to end ranges of spinal joint, and is that part of intervention? So yes, so the table actually can be mobilized using the provider's hand, and you can bring every facet joint to the end range of motion. So you can take that range of motion intersegmentally at every unit in the spine, through the range of motion, through passive, through active, and even into the up to the paraphysicological range. It doesn't go to the paraphysicological range, which produces the cavitation of the joint, which is what happens in classical high velocity manipulation, but the table actually helps take the range of motion through passive and through active. And it's a great mobilizing tool to enhance joint mobilization, especially in patients who probably shouldn't have high velocity rotational manipulation. So great question. Any other questions? Okay, I want to thank everybody for attending. Remember that QR code is only available for 48 hours to get the credit. Next month on February, the first Tuesday of the month, I believe it's February 14th, we will have a spine surgeon talking about the role of navigational and robotics in now some of the newer techniques in spine surgery. His name's Dr. Jin, and I look forward to seeing you all then. Zach and Barbara, thank you very much for your participation today. And Jonathan, thanks for your excellent work as well. Everybody have a great day. Thank you.
Thanks, Dr. Ben.
Thanks.
Have a good day.